kids in Canada. We're very excited to have her on. Again, if you're new to SDS or a new person in the SDS world, maybe a teacher or someone in an SDS patient's life that you just want to learn a little more about SDS. All our shows are on YouTube. Look up the Shwachman-Diamond Syndrome Foundation, and we upload all these shows. And there's just it's a really great starter pack for you to just learn in an easy way. And you could ask questions and everything. It's really great. Hi, Michelle. How are you doing?
Hi, Nicole. I am doing fantastic as I can be, I suppose. I love that. I think anyone who's been to camp will say their saddest part about camp is when it ends, and that last day when we're all kind of running around and packing. But like, I know a couple of years back, I was like just sitting on your porch and I'm like, you can't make me leave. I'm here. I'm not moving. You can come and take me out, Nancy Sincata. And I love that this has been like the camp that doesn't stop camping.
Like, yeah, that's true. We we're like, we can make camp as long as we want to make camp.
November, and we're like, oh, it's Thanksgiving. Let's go to camp. Who wants to go to camp with Dr. Kerr? I do. Pick me. Sounds like a great time.
So
I do hope it's been helpful. I know we've gotten a couple messages in from people that this has been really helpful for them. And I know we say it every time, but I love that this is a camp that is really accessible for everybody,
the whole world.
Yeah.
So I actually I was telling Michelle, we got a message in literally last night from Ireland, a family that wanted more information in this area. And I was like, well, actually, we have Dr. Kerr coming on tomorrow night. I don't know if they're going to be able to log on because I don't know what time it is in Ireland. But if wherever you are, tell us where you're logging on from, because we get a kick out of all the different places that people log on from, which is really
exciting. Do.
Yeah.
My next quarantine project, I'm actually going to either sew or paint or cross stitch or, something with my hands, a little map so we can put pins.
I love that.
And I'm really excited about it.
I love it. Oh, Kenny is on. Oh.
I also believe that we are broadcasting to YouTube tonight too, I think.
We are. Oh, someone from Roman School is on. Hi, Kimmy. So did you see it? Kenny's on. Amazon on. I know, we're very excited. So,
do you watch The Masked Singer at all, Nicole?
No, I don't.
Okay, so that's one show that my kid is obsessed with, and they bring back these like contestants or whatever to be guest judges. That's what I feel like Kenny is doing right now, because Kenny was a guest.
Totally, the masked judge.
Like a year ago, and so he's like, "Hey, guess what? It's me again. I'm here."
He does kind of pop in.
And I'm really excited for Dr. Kerr tonight too. I know if anyone's been to camp and had the pleasure of having a one-on-one with her, it's really hard to stick to your 15 minutes.
I was just going to say that.
It doesn't happen.
It doesn't happen. We're like,
with Dr. Kerr waiting outside.
So Peter and I, so we're kind of heading, Roman just turned 6, and we're kind of heading into having issues in this area, but we have sat through 2 sessions now, and we sat through the mini sessions, and I've even had a one-on-one with Dr. Kerr because we knew this was probably going to come. So so a reminder, let us know where you're logging on from. Reminder that these are uploaded to YouTube, so don't ask any personal questions that you wouldn't want on a public forum. And it was actually interesting. We were talking to Dr. Kerr about all the COVID precautions, Canada versus US. So she's again from sick kids in Canada.
Yes. And I think now is the perfect time more than ever to actually let's introduce Dr. Kerr and bring her up, and she can tell you a little bit more about herself. Hi, Dr. Kerr.
Hi there. Thank you so much for asking me to speak tonight.
Yeah.
Nice to see your smiling faces.
Yes, it's definitely weird in this time of COVID. I know it's we're all kind of longing for this human connection, and so it's this is the norm for Nicole and I. We're not near each other, but anytime I see her, I kind of get giddy. I'm like, oh, look at her.
I do too. I even get giddy seeing my actual hematologist like face to face, because I feel like I'm not 100% alone. Like, we actually cried the last time we saw each other face to face, because I was like, I just need you. I need you. Like, I need to physically see you, not just on the phone or telehealth. Like, we need each other big time right now.
Well, I really commend you for being able to organize this together, this forum. I think you've done a really great job trying to put it together. So
thank you, Dr. Kerr.
today. Oh, I said, thanks. You're going to make me cry because I haven't had my daily cry yet today.
Well, we're probably going to have a ton of questions. So we're going to do like we've done for most of the camp series and act just like we're at camp. And we're going to turn the floor over to Dr. Kerr.
All right. So I am a neuropsychologist and health psychologist at Sick Kids. I have been working at Sick Kids, probably 25 years, although I was away for a very small segment. And I first was introduced to Shwachman-Diamond syndrome by a group of clinicians at Sick Kids, Dr. Peter Dury, and asked me to start seeing patients. And so together we did, and some others did a research project. So that's some of what I'm going to present today, but I'm also going to present on some other research that's being done. So just let me share my screen. Oh, just a second here. Uh-oh, I think I froze. All right, I think you probably can see it now. So today I'm going to talk about the cognitive, psychological, and social functioning associated with Shwachman-Diamond syndrome. And I thought I'd start just by talking about what we know about Shwachman-Diamond in the brain, as it all starts with the brain in terms of thinking and behavior. Then really talk a lot about the neuropsychological challenges that can be associated for some individuals with Shwachman-Diamond syndrome. And throughout the presentation, I'm going to offer some strategies to support development. I'm probably not going to read all of those just in the interest of time, and so that you know that you can ask some questions at the end. So the SBDS gene was discovered in 2003, and what research is currently showing is that about 90% of individuals who meet the clinical diagnosis of Shwachman-Diamond syndrome have mutations in the SBDS gene, and now there's some other suspect genes that cause a similar or the same phenotype. The SBDS protein plays a role in ribosome biogenesis, which you've probably heard about from other talks. And the SBDS gene is expressed in all organs, including the brain. So what I want to say is just that within any syndrome exists considerable phenotypic variability. And I'm sure you recognize that in some of the physical manifestations of SDS. Within the brain, the variability can be traced in part to genetic variability. There's different mutations which are caused with the SBDS gene dysfunction. It can be caused some of the variability can be contributed by prenatal issues, a developmental level of plasticity, how old an individual is, and also some family or experiential factors. So just doing a little bit of Brain 101, our brain is made up of microscopic cells called neurons, and this is a single neuron in our brain, and we have about 86 billion of them. And they're responsible for receiving, integrating, transmitting information. And we look more closely at the anatomy, we can see here, these are dendrites. They're receiving the information from another neuron. This is called the cell body. And in the middle of the cell body is the nucleus of the cell. And it's the powerhouse, it's sort of the control center. And it sends messages down this long axon and then sends the information off to another neuron. And you can see this axon is covered in a sort of a fatty sheath. It's called a myelin sheath. So the neurons end up communicating with each other through the electrical impulses that are triggered down the axon, and it's triggered by the different neurotransmitters. The neurons connect with each other, making different pathways in our brain, kind of like roads and trillions of them. And so the system is really interconnected. And it's often compared to the complex electrical city of a big city, such as a Toronto. And this is a picture of Toronto here for you. The neurons are represented in the brain in terms of gray matter and white matter. So the gray matter is the outer shell, primarily, of our brain, or the cortex, and it contains those cell bodies, so the powerhouse of the neuron, and the responsibility is for integrating and processing information. The gray matter develops up into our mid-20s. The white matter lies beneath the gray matter, and it's the bundles of axons. So it's connecting the gray matter, and the job is to transmit the electrical signals to other neurons and passing information. And the white matter develops through our 20s and peaks about middle age. So in terms of just general strategies for brain development, there is a lot of information coming on board about the power of physical activity, both for gray matter development and white matter development. And more recently, there's been some information about mindful meditation in altering gray matter density. So looking at what we know about the SDS brain, this information comes from 8 studies, and all of them are quite small. So some of them are just single studies of one person, and no study is more than 9 individuals. So it's very small information, but this is the way things happen with a rare genetic disease. We do see altered structures in terms of the gray matter and the white matter, and we also see altered connectivity. So looking at the gray matter, there's transformed thickness. And cortical thickness is considered to be an indicator of gray matter maturation. So where in development is the gray matter? And it's sensitive to developmental changes. With the white matter, we see delayed myelination and reduced volume, among other things. So if there is alterations or damage to the white matter, then effective communication between the different areas of the brain can be disrupted. And we would say that's connectivity. And Sandra Parabelli in 2015 did a study where she was able to document that there were some alterations in the communication between some of the core areas of the brain. If there are impairments in the growth or the development of the brain, whether it's prenatally or early postnatally, then we would see this as being associated with a neurodevelopmental disorder. And the most popular neurodevelopmental disorders would be ADHD, an intellectual disability, autism spectrum disorder. So we look at the changes. They might be due to genetic predisposition, including genetic abnormalities such as SBDS gene dysfunction, or they could be due to environmental influences or a combination of both. Recently, there has been some ideas that dysregulated ribosome biogenesis may cause some neurodevelopmental disorders. And Hetman and Slominki have proposed a number of theoretical models. SDS was not among one of the diseases that they listed. But what we do know right now is that the method specifically designed for isolation of the brain ribosomes, and so the detailed investigations of the properties there are only very recent developments. So to my knowledge, the ribosome function in the brain has not been looked at specifically. We do have a number of neurodevelopmental studies. So there were 4 indications of neurodevelopment prior to gene discovery. Schwachman et al. Stated their patients experienced normal development. But then there were 3 studies, really about a decade apart from each other, that talked about delayed development and some concerns about intellectual functioning. Since the gene has been discovered, there have been a number of studies. The ones represented in purple were neuroimaging studies where they asked questions about development either by a survey or they did direct assessment of some skills, and they were both very small studies of less than 10. The dark blue studies are large studies, and they've looked at cognitive functioning, psychological functioning, quality of life, and psychosocial well-being. Well, I'm going to talk about all of the studies, but I'm primarily going to focus on mine. So my study was done in North America in 2010, and we had 32 families volunteer to participate. We had 32 children with Shwachman-Diamond between the ages of 6 to 17, and we compared their results on cognitive tasks, psychological tasks, social tasks, and so forth to 13 siblings who did not have Shwachman-Diamond syndrome, as well as to 21 age and gender-matched children with cystic fibrosis. And we picked cystic fibrosis because it's the leading cause of childhood pancreatic insufficiency, and Shwachman-Diamond is the second leading cause. When we look at parent report of early development, there are a number of studies that have reported delays. In the study that I did, we see that a third to a half of parents reported that their child was late to obtain their early developmental motor milestones, and about half were delayed to acquire their early language milestones. So if you have an infant at home and you're concerned about development, you want to try to get support from an occupational therapist, a physiotherapist, or speech and language therapist, depending on what your concern is, as soon as possible, just to try to get the intervention. Moving to the school years, we asked families about issues that might be related to learning issues. And so I asked questions regarding were children in a special class? Were they receiving learning assistance at school, or had they had a prior psychological assessment before coming to my study? And you can see that the rates are pretty high, particularly for receiving learning assistance or having an assessment, and they are higher than siblings and CF controls. This is not a North American problem. We see that families in Italy and France, about 2/3 of them are also reporting difficulties with learning at school. Most recently, Loveless did a survey study from the registry. She had, I think it was 123 email addresses and sent home a survey, and she received 42 responses on 49 individuals with SDS, and 95% had reported that their child had problems with learning, emotional or social issues. And from an academic progress point of view, I would say that each of these can play a role in success. So looking at a neuropsychological assessment, it's really to understand brain-behavior relationships. And we do an assessment of a very comprehensive group of cognitive skills. We look at psychosocial well-being and adaptive functioning, and we analyze and interpret the results based on a number of factors, including an individual's age, whether there is anything on an MRI that an individual had, what their education was. We also look at the course of the disease, what medical issues, fatigue, whether there's been medical treatments that might play a role as well. When we're interpreting results, just let me back up. The tests are made for individuals of lots of different ages. And when we're interpreting results, we only compare a child to other people their age. Or if I'm seeing an adult, we're comparing an adult to other people their age. So if I were seeing a 10-year-old and I just took 100 10-year-olds off the street, not with Schwachman-Diamond, we would expect this normal distribution where we get 50 out of 100 people to fall within the average range, 25 out of 100 to fall above the average range to varying degrees, and 25 out of 100 to fall below the average range to varying degrees. And we would only expect that 2 out of 100 would fall at the very extremes. Most neuropsychological assessments will commence with looking at intellectual abilities, but they don't end there. So there's numerous studies that have reported weaknesses in intellectual abilities. We found that a range of abilities is observed, but that the distribution is shifted downwards, so that we're only seeing 6 out of 100 fall above the average range, and we're seeing 50 out of 100 falling below the average range to varying degrees. So not surprisingly, these results are significantly weaker than the normative data, and they were also weaker than siblings and CF controls. So overall intellectual functioning is comprised of visual skills and verbal skills, and the same sort of pattern existed. But there are 3 different tasks for visual skills and verbal skills. And as a group, the children performed below norm siblings and CF control on all 3 visual tasks, but they were only weaker than norms or norm siblings and controls with social comprehension. Their word knowledge and their ability to compare norms, compare words didn't differ from siblings or CF controls. So I just panicked there because my next slide disappeared from view. So these are just some general strategies to support weak reasoning skills. On the left are some skills for school and home. And then at home, there's some things that you can do in terms of playing games, problem solving out loud, and trying to support classification skills for more abstract reasoning. And I'll talk a little bit about more about that when we talk about executive functioning. But intellectual abilities fail to capture the complexity of cognitive experience. So neuropsychological assessments encompass lots of other skills. So one of the things that we looked at was processing speed, and we specifically looked at visual motor processing speed. And this distribution is looking at a combination of scores from a speed of transcription task and also a speed of visual scanning and matching that required a simple motor mark. And the results were weaker than norm siblings and CF controls. Practically speaking, weaknesses in processing speed can result in slower reaction times, difficulty working methodically, difficulty keeping pace, and overall gaps in learning and frustration. So the strategies that I've offered are really for processing speed in general, not specifically to visual motor processing speed, and you can read these on your own later. We also looked at visual motor integration, which is copying simple to more complex geometric design. So it involves fine motor control and some visual spatial reasoning. And you can see that there's a large proportion of individuals who are mildly, moderately, or significant below typical development. So the strategies that I offer are really for fine motor skills for this. I mentioned earlier that word knowledge as a group was within the average range. So we had looked at their ability to define words and to compare words. Where we saw some difficulties was in higher order language. And that really goes beyond basic vocabulary and is related to advanced language processing. So it requires abstract reasoning and deductive reasoning. Where we saw the weaknesses were in making inferences, trying to figure out what went on when you only get part of the information, understanding figurative expressions or metaphors, and knowledge of synonyms. And this last measure is often used as a vocabulary measure, but I'd already seen that the vocabulary was adequate, and so I really think it was not knowing synonyms. So the strategies that I'm offering are specific to each one of these skills. Return to executive functioning. Executive functioning relates to the frontal part of the brain, so right behind the forehead. And these skills develop up into our early 20s. It includes attention and working memory, planning, organization, time management, task initiation, and sticking with it or perseverance when you're on it, and flexibility. I'll start by looking at attention. So this was looking at parent report, and Loveless et al. From her survey reported 50% of parents reporting difficulties with inattention. And Sandra Parabelli and I used a standardized parent report measure. So it's compared to that normative data. It was called the Child Behavior Checklist. And we are seeing quite high rates in North America and Italy, which are significantly higher than norms and controls with CF. I will point out that the apparent difference between North America and Italy is probably not real. Sandra Parabelli included children who were 3 to 6 years of age, and I only included children who are 6 and older. And oftentimes we don't do enough structured activities to really document inattention in the 3 to 6 group unless there's something really significant. On formal assessment, I looked at span of attention, which is how many chunks an individual can process and springboard back. Working memory, can they manipulate those chunks very briefly in mind? Selective attention, can they focus in on a specific target and ignore distractions? And sustained attention, can they stay focused for a long period of time, particularly when it's boring? So schoolwork would be a good example, but video games would not be. And as a group, the SDS participants were significantly weak relative to norms in each of these areas, and I've just shown the distribution for sustained attention. And they were also weaker than CF controls in all but selective attention. So I think it's safe to say that inattention and ADHD are significantly more common in children with SDS than in the general population. And we would think that any educational and behavioral supports used for any child with attention problems can also be effective for children with SDS. And so I'm going to leave you with some for school and at home. We looked at executive functioning in a little bit more detail. So this is just looking at the distribution a little differently. On the left here, you see 50 out of 100 that are in the average range, 25 out of 100 that are above the average range to varying degrees, and 25 out of 100 that are below the average range to varying degrees. So we looked at mental flexibility going back and forth between two tasks, and you can see that about 60% struggled to some degree on this task. That was the accuracy. The next column is the speed that it took them to do it. And so even when people were accurate, it was taking them a lot more effort and a lot more time to actually do the task. If you struggle with mental flexibility, it's hard to do a divided attention task. And a divided attention task is doing two equally important tasks at the same time. And only one of our 32 participants performed within the average range. The last task was an ambiguous problem-solving task, and this is looking at errors, and you can see that they struggled as well. So the weaknesses that we see in executive functioning is relative to intellectual abilities. Executive functioning is really important to success in high school and college, and also in employment. So I'm providing a number of strategies or recommendations to support development. One of them, really from an early age, is to set up routines for a child to follow, because when activities become habitual, they require a lot less active processing and are a lot less likely to be forgotten. Play really modifies the development of the prefrontal cortex, which is responsible for the executive skills. So you want to look for games that challenge and adapt as you play, that are intensive, and that cross-train. So they're doing more than one thing. And there's a nice resource by Lynn Kenny, who's from the States, on 70 play activities for better thinking, regulation, learning, and behavior. The final recommendation or resource is from the Center on Developing Children at Harvard University. I think I've shared this with you before, but what they've done is they've looked at everyday activities that we do at home that you can engage children from infancy through adolescence to support the development of executive functioning, and they sort of break it into age categories. We looked at memory, and Sandra Parabelli looked at memory, and really overall we did not see concerns about memory performance. We're looking at psychological well-being. This is the same standardized parent report that families completed. We do see higher rates of somatic complaints. The apparent difference between the North America and Italy, again, is probably related to having 3 to 6-year-olds in the study. As we get older or live with a condition longer, we may have more complaints that are disease-specific, or be able to express them better at least. We also saw rule breaking, anxiety, and depression. So looking at that a little bit more closely, we're seeing that about a third to over a third are showing sort of hyperactivity and impulsivity. We see a high rate of acting shy. We also see those rule-breaking behaviors at just under a third, with oppositional and aggressive behavior. And we see a fairly high rate of emotional lability. Loveless in her survey also said individuals self-identified concerns about prognosis and about transition to adulthood, and certainly those would weigh heavily on psychological well-being for the individual with SDS and also the family members. I would also say there's probably feelings of differences due to educational challenges or missed school due to doctor's appointments and hospitalizations and so forth. So I'm offering strategies for behavior. Behavior is a form of communication, and poor behavior is often related to some sort of skill deficit. So if a child isn't able to express his or her frustration verbally, they might throw a tantrum or throw a pencil. If they feel left out, they might push another child. So we really want to try to identify and support where the skill weakness is and try to understand them from that perspective. From a psychosocial well-being, we want to celebrate strengths. All children, all individuals have strengths. Keep a growth mindset, provide opportunities to feel normal, but if you're really concerned, to get support from a counselor. In looking at social functioning, the same parent report that we use, we see that about a third of parents are reporting social problems. We get more information from formal assessment. I've already mentioned weaknesses in social comprehension and higher order language skills. Blad et al. In France did a study looking at social cognition or theory of mind in teenagers and found that this was weak. We also see additional parent report. So the study that I did, about 6% had previously been diagnosed with autism spectrum disorder, which is much higher than the 1.4% we expect in the general population. And in Lovelace's study, she did find higher rates of social anxiety, social difficulties due to short stature and missing school, and delayed maturity relative to peers. Which brings us to adaptive functioning, and that's really looking at social cultural standards for personal independence. It covers a wide range of developmentally driven functional competencies. We did find some weaknesses there, and it may be that medical issues necessitate dependence on a family when independence is key, or that because of the life-threatening nature of the condition, the parents are more vigilant and reluctant to facilitate total independence. In general, we think of as adaptive functioning as an indicator of positive life outcomes in terms of educational, interpersonal, and employment. And so some of us might think about that as, in part, as quality of life. So I just want to give you a definition of quality of life. Oftentimes, studies will call quality of life what they're really looking at is functional disability and health, which is whether somebody can do an activity or not. So can you walk for 4 blocks? Health-related quality of life relates to the satisfaction of whether they can do it or not, or their concern about whether they can do it. So if I can't walk 4 blocks, but I don't care about it, then it hasn't impacted my quality of life. And health-related quality of life is just one component of overall quality of life. So Sally Kinsley in Leeds did do a study on quality of life using a standardized questionnaire. She had 7 children parent dyad complete the questionnaire, and more than 50% of parents reported below average scores, mostly related to that functional disability and health, which this measure primarily measures, but about 30% of the questions, or 33%, are related to quality of life. So they did recognize that the child's health interrupted family activities or was a source of tension. Children reported overall good quality of life, but they did recognize that their health was a source of tension. Sandra Parabelli also looked at functional disability and quality of life. She found that patients with SDS scored lower than those with CF in terms of physical performance, physical pain, daily activities. And that adults show lower incidence of independent housing, marriage, employment, and driver's license obtainment relative to CF controls. The quality of life, looking at satisfaction, had to do with the socialization piece. So I'm giving you some strategies in terms of supporting autonomy and pro-social skills so they can be more independent, but also be more interactive. So just a quick summary of neurodevelopmental issues and SDS. There really is a spectrum of neurological manifestations, and we see that intellectual functioning is shifted downwards. Some individuals are quite bright, more individuals are struggling to some degree. We do see issues with executive functioning. There are some behavioral presentation concerns in terms of aggression, impulsivity, and inattention. Some individuals with inattention will meet criteria for ADHD. There is a high rate of autism spectrum disorder. I didn't show a slide on the rate of oppositional defiant disorder, but that's there as well. And each of these issues can contribute to social or adaptive functioning and social problems, but they can each contribute to academic performance. So this next is a resource. Really, it was developed to assist educators and counselors as they work with youth from child to adult, and it discusses critical transition period. But there's very specific information about what the challenge might be and how to support child at school or how to support them in the workplace. I've left you a slide to look over on your own on fatigue, because a lot of chronic illnesses are associated with fatigue. I'm winding up now, but I do think it's important to do a neuropsychological assessment every few years. The reason why it's important is because of the brain involvement in SDS. We believe that the neuropsychological difficulties are primary consequences of SBDS gene dysfunction on the brain. We know that there are risks to mental health and psychosocial functioning, concerns about prognosis, doctor's appointments can interfere with inclusion activities, just coping with different treatments. Some medical practitioners may want an assessment to evaluate response to treatment. And, the good news is our brain continues to develop based on continual stimulation from the environment. And so the picture at one point in time is not going to be the picture at another point in time. And we want to make sure that we have a good idea of how an individual is doing so we can support them where they're at. So this is a rough guideline of when I think about doing assessments. These are cognitive and social stress points that we see in general. Sometimes people are compensating or just getting by, but the stress point is a tipping point where issues emerge because the expectations change. And so that's included with the draft consensus guidelines. So in conclusion, the cognitive, psychological, and social consequences of SDS are secondary to structural changes in the brain, presumed to be due to dysfunction of the ribosome. The neurodevelopmental issues are lifelong, and so we want to have early identification and intervention to improve outcomes for anyone who's affected and their families. And I thank you for your attention.
Holy cow.
Was that a marathon?
Listen, I've had a Dr. Kerr presentation and like multiple one-on-ones that have gone well over my time limit, and we're like hiding up in a room at camp, and I was taking notes. I was like nudging to my husband. I'm like, listen to the episode, listen to this part, but we know all this. I mean, not all of it, but whoa, that is, I think when new families join, a lot of the things you hear about SDS are the scaries, the bone marrow, the pancreas, the other immune issues that come with it. But I don't know how many families really understand that under all of that, there's a deeper concern about the neurodevelopment layer. And then once they can put the pieces together, they're like, I had no idea that that had anything to do with SDS. And it's just really interesting how many families we get that tell us, they had no idea.
So I think in reflecting on that, a child has SDS, and it's represented in the pancreas, in the bone marrow, in the brain, for some people in the teeth, in the bone. So it's one condition, it's just how it's represented.
Definitely. We had a couple of questions come in. And a couple you might have answered, but one of them, and I was wondering this too, typical with clinical studies, do these studies only involve and study patients who are genetically confirmed with SDS, or is it also studying clinical patients?
So my study was only genetically confirmed. And we just did that. We know that there's some other genes, but we just really wanted to make sure that we were comparing oranges and not oranges and tangerines until we understand what's going on. So I'm not sure about some of the other studies, but I can say that for my study, we had genetic confirmation.
One of the best aspects of the show is that I have a clinically diagnosed child. Nicole has a genetically diagnosed child. So we can see the oranges and the tangerines like right next to each other. And so as a clinical family, I totally understand why it's always genetic people, because you have to have a base group of something that's in common. And a lot of clinical kids do not have anything in common. So I totally get it. It was just a question.
But you don't need the genetic confirmation to be diagnosed with the condition. The diagnosis is clinical, based on exocrine pancreatic dysfunction and bone marrow failure.
Correct. Thank you for the clarification on that, because it's also a question we get a lot. As a clinical family, I'm usually referred to them to kind of help them through the ropes. Do you feel that if an SDS child receives special education and supportive care during school, that it will help them be independent in adulthood?
So not necessarily. I think that when you're receiving special support, you're getting support for the specific needs of your child, and you're letting them grow to the best of their ability. There is probably an upper level. We see that 1 in 5 meet criteria for an intellectual disability, and they may not be completely independent in adulthood. The individuals in the orange zone may be semi-independent, but need to be working in a structured work environment, and it may not be a really high earning job. So we just want to give them as many tools and as much support so they can keep making gains. What I will say, and this is my experience across diseases, is if you're teaching a 10-year-old who's functioning at a 5-year-old level, at a 10-year-old level, they are learning nothing. So you got to come down closer so that they can actually reach to what it is that you want to do. You don't want to ever teach exactly at their level. You want to have little increments where they're reaching and keep going up.
One of the questions that came in, and I think you sort of half answered it, so I'm going to rephrase it a little. The question originally was, do you think it's possible for SDS patients to be able to be independent in adulthood? But I'm going to add on that and say, what do you think are the best supports we can give? We're seeing a lot of teens, older teens, struggling to transition to independent adulthood. It's quite a concern in the SDS community at the moment. And so what are some of the supports we can give them or show them, or resources for that age group to kind of help them transition easier?
So I do think you have a number of successful individuals that come to camp, and I think that lets you have a growth mindset about where individuals can be. If you have younger children, I think you want to start now in giving them independence where you can give them independence. So, if they can't dress themselves, still give them a choice of whether they're going to wear the blue shirt or the red shirt. If they're taking their medication, what's the chaser going to be? So you involve them in those sorts of things and some decision making from a young age rather than taking it over. Let them answer the questions in the medical office. With the older group, it's hard because it's probably pretty individualized in what it is that they're able to do in terms of where their cognitive abilities. We've seen some really bright individuals with SDS, and we've seen other people that are struggling more in that area, and we see some people with more mental health issues. So I think it's really independent, but that Pathways to Success, I was part of the development of that. There are some really nice pieces to help with critical transitions and what you can do to allow an older adolescent to be more independent and to be more successful in the workplace. So that's one resource to start with anyway.
It's really interesting because a lot of us talk about the struggles our kids are having at home or in school, but when we talk about our kids in the hospital, they are light years away from so many people, even adults, right? Just their ability to advocate, choose, they're just amazing because they just have been through so much. My son was just in the ER, and his ability to advocate for himself and tell everyone in the room what he needed. It was just amazing. I was really so impressed. I was like, he's just 6.
Oh.
He's 6. So, and I see him doing that a little in school, and I'm really impressed with him. So I know, and I hear that story from all the other families. So
it's really interesting to see how our kids can grow and adapt to all these things, and that, these kids should just be being kids. But in the reality is a lot of these kids don't grow up with any sort of, normal, atypical childhood. And so I can see my kid, and sometimes I have to remember that he is a kid having a hard time. He's a little person with big feelings, having a hard time on the floor over bookwork, when I can see him as such a mature child in the ER, advocating and saying, no, I want this arm. No, it goes right here. No, I don't want to talk. I don't want you to talk to me when I'm going to sleep, or I don't want you to. And so I can see him as such a little adult. And then he's having a tantrum on the floor, and I'm like, what are you doing? Get up. You're a tiny adult. And so for me, it's almost retraining to kind of, like you had said, when you're teaching someone who's here, there's going to be this gap of confusion. Yeah, and I think that's true too for the medical trauma and all of it. It's kind of crazy.
Yeah. The other thing is that, it never ceases to surprise me how well kids can do outside of the home. It's kind of like they rise to the occasion, they know what's expected, and they can do well, but then they need an escape valve. So it's taken them a lot to do whatever that they did, and so they just need to decompress when they come home.
Yeah.
So sometimes when we come home and we say, "How was your day? What did you do?" What they really need is just
To
time with their
decompress.
favorite
That's really
activity
all
before
kids.
anything,
Yeah.
so that they don't have that meltdown, or not to have expectations put on them because they feel like they're overworking all day long.
So I had asked the support page for questions for you or just things to ask you. Of course, they had a lot to ask. But one of the most overwhelming things they messaged me was how to not overwhelm the school. Because we, of course, overwhelm them with the blood stuff, right? Like they're just like, whoa, what if, it's so overwhelming with the blood stuff. And then they're going to the nurse every day for Creon. And then all this brain stuff kind of gets pushed to the side because it's not life threatening. So how do we not overwhelm the schools with, or get them to also see this stuff, I guess? Because it seems to be, sometimes it's layered, right? Sometimes they have multiple learning disabilities or multiple things going on. And especially when a child enters school, it's hard to unwind all that stuff. And I think the schools, from what I heard, the schools can sometimes get very overwhelmed with it all.
Yeah, it's hard to understand things that we don't experience. I think we're much more concrete when it's foreign to us. So I think that the best that you can do is deal with the medical issues first, because they're most pressing and they can be life-threatening, right?
Yeah.
And then once a teacher gets to know your child, then go and meet with them and talk about where your concerns are for your child, just like any other parent would do. That you do want to see your child have an assessment in order to help them learn, and here's the evidence for your request. And then you want to work with them. And I think the working as a partnership is really key. We all come with different lenses. There's the teacher, there's a medical piece, there's a parents and what you see. And really, everybody wants the best for the child.
They
So to try to advocate for your child in a conversational kind of way and saying, we're all in this together, and what strategies are you using at school that I can use at home? And I found this was really helpful at home. I wonder if it will work at school, rather than going in great guns. But I know when families are not heard at school, it becomes much more difficult to do that, right? You become a mama bear or a papa bear.
I'm sorry, but someone from Roman school is on here, and I'm we're so used to like fighting for every little, like, getting our child diagnosed. Everything is, we have to fight everything. We're just so wounded. By the time we get to school age, we're like, please make this easy on us.
Just imagine.
I'm sorry to Roman school. We're getting there.
I just imagine us walking to school, Nicole. Now I homeschool, but like if I were to walk up to school like with like a bulletproof vest that's like torn and tattered, and like pants that are missing half a pant leg, and we're just like, listen, you're either gonna like do this or you're not, because like I'm already in flight mode and I've been here for 7 years. So do you have coffee for me, or are we doing this the hard way? And it's like I always feel really bad. My
friend made me a shirt for the ER that says Dragon Mama, because I'm just like, you're not going to poke my kid this many times. You're like, I'm just like, no nonsense. Okay, we have a lot more questions to get through. So
I did see a question on tests, and I wouldn't get hung up on the specific tests. So the Wechsler scales, or whichever one is most age appropriate, is probably most widely used, but I am not promoting Pearson particularly. There are other measures. There's the RIAS-2, there's the Woodcock-Johnson cognitive. That gives a GAI. I don't typically use it. I use that as a supplementary test. But you don't just want to stop at intellectual functioning. You want to have assessments that go beyond that, because they really don't capture everything. And can you hear me?
Yeah, we can hear you.
Okay, because my screen just froze, so I was like, so I will say that, if I have a 10-year-old and I give the whisk to, It's meant for children who are 6 all the way up to 16 years, 11 months. And they're not scoring well. And all I can say is that they're functioning below a 6-year-old level. I will probably stop it and I will pick another measure. So it really is up to the psychologist who's giving the measures to try to use all their training to decide what's the most appropriate assessment for your child. But it shouldn't be dictated which measure is used.
The next question right after that was, what supports do you recommend to support the kids with all these medical interventions?
Yeah, I think some of the, well, I'm not sure exactly what that is, but if all these medical intervention, is that what you said?
I would guess my take on it would be, what types of supports would you put in place for the school system, I would think, and I can, Leanne, correct me if I'm wrong. What type of supports would you put in place for the school to kind of decompress or to, help navigate through medications at school or the behavioral challenges that come from it, maybe?
Yeah, so the behavioral challenges for the biggest part, I would just say, is to try to find activities that the child enjoys and using them in between. So when you can see, usually there's something that's triggering a child, and you know what those are, so you're going to watch for the reaction. And, they can't just avoid activities, but to work on it a little bit and say, we're going to just do this for 5 minutes and you can take a break. Movement breaks are really critical for almost all children. Just to move, it actually engages attention better so that kids come back refreshed. And so that's another piece that I use on a regular basis.
Can I ask a piggyback to that? So I know a lot of SDS kids have these frequent movement breaks, actually. What specifically would you recommend? I know one child I can think of has a mini trampoline, but he's very small, the child I could think of.
It doesn't have to be big. Yeah, it doesn't have to be big, if something needs photocopying and they can walk to the office to get it photocopied. If they're going to go sharpen the pencil up at the desk, that it's their turn to wipe the board so that they're getting up and doing it. Physical daily activity should be part of every classroom anyway, not where they get up and they do something, but these are just kind of little ones to give a break to stop the volcano from going, really, right?
Yeah.
To kind of catch it in the act before it happens.
I'm sorry, Leanne did come back and clarify that her original question was, let me go back up, sorry. What supports do you recommend to support the kids with all the medical interventions? And she then clarified and said with having to go to the hospital all the time and working through the trauma. So totally different bowls of pasta.
My son is in this therapy, actually. My son is in medical play therapy with a therapist that specializes in chronic life-threatening illnesses. That was really hard to find someone, but it's been very expensive for us, though.
Yeah, so I think it is very difficult, and then it's sort of outside of what it is that I do. And our medical systems are a little bit different. So at Sick Kids, we do have social workers that are working with most units, and I think that they are really critical in terms of supporting children and their families through all the hospitalizations and feelings of trauma that they go through from going through all the investigations that they have to go through. So I don't know, I expect that each state's a little bit different, and it depends on your healthcare. But speaking with them, there are some books, I can't think of them off the top of my head, but if I can come up with some, I will send them to you, and then you can share them.
We have a couple that we really like. We love the Osborne books, the Shine a Light series, and you put a flashlight behind the page and it kind of lights up. It's cool. But we have one about the human body. We have one at the hospital. I'm ironically using it as a coaster right now, but we really like these Joy Berry books, these Help Me Be Good books. There's, they're also holding my computer up. There's Fighting, Disobeying, a lot of just very easy life skills, social skills that our kids have a really hard time understanding, but there's some that are centered around the hospital. And I think another good resource to find is that your local hospital, your children's hospital, wherever your home hospital is, ask about child life. Our home hospital is an amazing child life department, and they come in and they almost advocate for you guys. They'll say, okay, so your kid has to get a poke. Do you want the iPad, Nathan? Do you want bubbles? What do you want them to count to? And it really helps him kind of understand. And I'm going to brag on Nicole for a second. When she had said earlier that she was seeing Roman advocate for himself in school, I would love to see Nicole's strategies where she has laminated bookmarks for her kid that has his calming strategies on it.
He actually pulled it out on his own to help him. Yeah, who knew? Yeah.
Leanne, you can totally do something like that for medical things. After you get a poke, what do you want? And that also helps them decide and see and make a choice about it too, I think.
So following up on that, so one of the group of children that I work at, we do talk about your coping toolbox, and some of them are tangential things, but you can't always carry around those tangential things. And so then it's finding strategies that work for you. Is it deep breathing? Is it counting to 10, even if you have to count to 10 times to calm down? Is it doing imagery and thinking about things? Mm-hmm. I also work quite closely with a child life specialist in one of my positions. And one of the things that I really like about her is the activities that she does for normalization. So yes, all of this medicalization is going on, but she does activities to help find out who are you and what are you about, and self-expression and normalization, which I think is really key as well. Yeah. So thank you for bringing child life up.
Yeah. I love our child life department. We haven't gone to the hospital for a lot since the pandemic started. We've done a lot telehealth, but we did have to go for an appointment a while back. And I found that, all the playrooms are closed. Everything's sort of out of whack. But they've created this TV show where it's showing on the patient TVs, and they have these child life people come into the studio downstairs and do silly challenges like the pie face challenges. And so they're still finding ways to make kids laugh and really interact with them from 6 feet apart.
Child life rocks. They had my son do a scavenger hunt, and he lost his mind. He was so excited. Okay, we have a lot more questions. Sorry. Okay, so Savannah said, my son is getting evaluated for possible ASD and early intervention in general. This has given me a lot of good information to give the diagnosticians, teachers, and to use at home. Thank you so much. We love you, Savannah.
Yes. And I like the one right above that. It was Julie. And we all know President Julie as President Julie, but she said, I think what you guys are doing here is amazing. To facilitate this kind of information to your friends who don't have a familial SDS connection helps us be more supportive. And I think that's huge. I think one of the areas we struggle with as a family is family support or other support where they love us and they love us deeply, but they don't know it as deep as we do. And so it's hard for them to relate.
So hard. You feel like an alien on another planet.
It's like camp for everybody.
Yeah.
I love camp for everybody. It's my favorite.
Did we get through all the questions?
We did, unless there was more from the support page, but.
No, we're good. We're good. Oh, I did get a question from the support page asking about dyslexia and dysgraphia.
Oh, yeah. Very good question.
The difference between them?
Well, I guess it seemed like a lot of the kids were getting diagnosed with it kind of later in elementary school or mid-elementary school. And they were like,
within SDS, or is it just kind of something that's, oh, hey, look at this too?
It seems that they seem to be getting layers. That's what it seemed like. Oh, my child just also got diagnosed with this recently. Dysgraphia or dyslexia.
Yeah, so dysgraphia really is just relating to the issue with the fine motor control and not being able to write things down to the way that you'd like to see that. And so sometimes that can help with, in our school system anyway, getting a computer or voice-to-text software, a scribe to do some work. Dyslexia is really a term that relates to symbol processing in part. I think a lot of us think about it as being a reading disability, but it actually can impact on spelling and some aspects of math for the symbol processing. So, we did look at academic functioning, and I think really when you look at these sorts of things, it depends on the degree of difficulty that a child has, whether they're going to meet one of these types of diagnoses. So it's probably on an individual level. the labels or the diagnoses are still part of SDS. It's just the way that it's being manifested.
Yeah.
And labels really help others understand how to support your child, because there's a wealth of information about how to support dyslexia. There's a wealth of information how to support dysgraphia. There's a wealth of information on how to support dyspraxia. So it's really, the label just helps people who don't know SDS say, oh, this is what I can do to support your
Yeah,
child.
because no one knows SDS. I have one final question. Has anyone studied the environmental factors, specifically, like, I think Roman was around 3 when a leukemic marker popped up, and they said normally we would do more frequent bone marrow biopsies, but now there's recent studies about anesthesia and learning disabilities. Has anyone studied those specific environmental factors like frequent anesthesia, or how long it took for the pancreatic insufficiency to get diagnosed and they finally got proper nutrition or proper school supports, and how that all can snowball for a child? I could see how easily, especially a school age child, it could lead to anxiety and depression, and the longer things go without getting helped, right? Or
Or not
especially
being understood.
yeah.
Yeah, not being understood.
They could get more and more frustrated, I think.
Yeah, for teens, unpredictability of whether there is going to be a life-threatening issue, that weighs heavily as well. So in the study that we did, we particularly picked CF as a control group because of the pancreatic insufficiency.
And the lack of nutrition.
And so we are seeing the issues. We really didn't think that it was the failure to thrive that some infants experience, or the pancreatic insufficiency. Some individuals with SDS, as you know, become pancreatic sufficient.
Yeah.
Doesn't mean that their pancreas is working perfectly, but they have a sufficient amount of natural enzymes to digest their food. And others don't, and they need a longer term. So that's another one of those phenotype of variability. In terms of the procedures and all those things that go on, I don't think that there's been any real research looking at the long-term outcome of that and how we would assess that necessarily.
Yeah.
With anesthetic, there are definitely some studies looking at the number of times a child goes under anesthetic, but I don't think it's just the number of times. It's probably
length,
the
right?
length of the time that somebody's being exposed to it. So, that's hard, because if your child needs medical treatment, they need the medical treatment. So, I've seen it's a concern as a family, maybe when you know that there's that cognitive piece. So that's hard.
Which one
but
do
it's
you
nice
choose?
that your doctors are aware that there's that cognitive piece associated with that now.
Yeah, they were choosing not to do more bone marrow biopsies because they knew of that learning piece. Michelle, did you have anything else before I jump to Giving Tuesday?
No, I don't think so. I think let's jump. Let's jump hard.
Thank you, Dr. Kerr, so much. This was so needed. I needed it so much. We've been getting a lot of messages, and not to mention, like, these kids, like, all kids are really struggling now with COVID and everything. And, SDS kids are no different. They're, struggling. Actually, I've heard a lot of SDS kids, I don't want to say no different. A lot of SDS kids are very resilient because they're used to being home. They're used to wearing masks. They're used to their temperature. Us moms have like a tool belt of thermometers on us. Like, they're used to the hand sanitizers. Oh, Leanne said, where can I get more information about anesthetic? My child is going under again this week.
Yeah, I wouldn't stress too much about it, honestly. I just wouldn't. My son has been under different procedures himself, and I did worry because I know a little bit too much. So I don't think there's anything well, there may be something in lay. If you did a search, you might be able to find it. But it's not highly conclusive information, but it does seem to impact maybe attention, maybe reasoning skills a bit, but that's a prolonged and a lot of multiple visits. So
yeah.
But if your child needs it, your child needs it, and the medical care comes first. Truly, just focus on that you're doing what's best, and have the discussion with your doctor at a later date if something else is needed.
Absolutely.
Dr. Kerr, do we wish you a happy Boxing Day? We don't wish you a happy Thanksgiving. Thanksgiving is coming up for us. We wish you a happy Boxing Day, right? Is that the next
Boxing
holiday?
Day is after Christmas, but I'll
It's
take it.
after Christmas. Oh, don't you have
Yeah.
a holiday right around Thanksgiving that you guys celebrate?
Yeah,
We don't. We had Thanksgiving in October, and
Yes,
we were
really.
told not to socialize with anybody. So
Yeah.
it was the quietest Thanksgiving I've had in my entire life.
Well, happy last Thursday in November day.
Thank you.
Thank you so much, Dr.
Yes,
Kerr. I'm sure we're going to get a lot of
you.
we're going to get a lot of questions, I'm sure. We thank you so much for your time.
Yeah.
You're welcome.
Thank you.
Good night.
Thank you, Dr. Kerr.
So we're going to jump to Giving Tuesday. So first we want to let y'all know, please be safe for Thanksgiving. Please, please, please be safe. We care about y'all. And then second, Giving Tuesday is the first Tuesday after Thanksgiving. And of course, we'd like you to choose SDSF. Michelle and I have been working on videos for y'all. There's a coffee video out right now that even $5 goes a long way. And SDSF is funding a lot of research. So this upcoming week, we're going to be talking more about that research and where that money really goes and the impact it really makes. So
yes, really absolutely. I had a lot of fun doing voiceovers for these videos.
You can totally do voiceover work like as a living.
I mean, I don't have to brush my hair, so I can totally do that.
You're really good at it. Thank you.
Right up my alley. I think, yes, you guys are definitely going to be seeing more about Giving Tuesday coming up in the next coming weeks, because like Nicole said, it is not very far away. And I'm kind of excited because this is the first time, so it's kind of like SDSF Live, but in like a 2-minute version. Like you guys are going to get to hear from some of the doctors who you're supporting, where your dollars.
Yeah. We had them make these mini videos, and they did a really great job of just where that money goes. So we're going to take a little break because obviously the holidays are coming up, and we want to be respectful of that. But we have Dr. Lindsay Coleman, who's doing a lot of cancer research in Boston.
Yes, that's going to be a big one.
Coming up in January.
We want to get Dr. McCaslin back on because we know that COVID is affecting the lungs, and we want to get an update on where research is now and, kind of the updates on it. And then, was there anyone else, Nicole? I think we were going to try to get like a therapist, like maybe a play therapist.
Yeah. And then we have a new series coming up that's a secret that we're going to talk about after the first of the year with adults. So
pretty excited about that one.
Happy Thanksgiving. Be safe. And
remember,
wear your mask.
Wash your hands.
Wash your hands.
Eat a lot of
turkey. Everyone that logged on. Thank you.